il a dit qu'il lance.
Ok, ben allons-y alors. So, welcome everybody and let's start our event of today.
Okay. Good morning, dear colleagues, dear students, dear guests. Welcome to this third Sino-Luxembourgish webinar on COVID-19 issues. I wish to stress that the timing is maybe not appropriate for those who are working hard in Luxembourg, but we apologize, but we have to comply to the jet lag and of course also to the availability of our speakers, who are not less busy than our doctors here in Luxembourg. For those who cannot follow, please be aware that starting tomorrow, the webinar will be accessible in replay on our e-learning platform at the university website. And as far as I know, tomorrow will be rainy weather, so that will be a nice opportunity. For those who have the chance to be with us today, don't hesitate to type in your questions by the chat function, and they will be forwarded to the discussants and to the speakers. The topic we choose today is one of the essentials and most complex issues with these COVID-19 patients, which is the intensive care management. And to illustrate this with the huge experience from the Weijun Hospital in Wuhan, we have invited today Professor Handong Jiang, who is pulmonary physician and intensivist, and followed by Professor Weijun Wang, who is a cardiothoracic surgeon, head of the department at the same hospital, which is one of those fantastic things that are possible only in China, a hospital that has been built up in 2 weeks' time. After the two speakers, there will be a discussion that will be animated by, again, two colleagues from Weijun Hospital, Professor Xin-He Xu, who is Vice President of the Emergency Admission Service, and Professor Han Ji, who is a cardiologist. We have also an expert from Luxembourg, and I welcome Professor Claude Brown, who is medical director at the Robert Schumann Hospital in Luxembourg. So we will get back to more details about the discussions a little bit later, and I think we should leave the floor now to our distinguished speaker, whom I thank wholeheartedly to have accepted this task.
Now let us welcome our speaker. I will help to prepare the presentation. 蒋老师，您可以开始了。Please, Professor Jiang.
这里就一张一张点击就可以。
这点好。
这个鼠标就可以。
Dear Professor, ladies and gentlemen, and medical students, it's a pleasure to be here to discuss something regarding the treatment of severe COVID-19 pneumonia and some experience we work in the Weijun Hospital and some kind of expert consensus issued by the Chinese government or expert. And here in China, especially in the January, February, April, we have a different kind of protocol for the treatment of COVID-19 pneumonia, and and we have the version of treatment strategy issued by different society or professional society, but the most we use most the one who holds the most influential or most authoritative is the version issued by the Ministry of Health, and those are the expert opinion regarding the treatment and the diagnosis of the COVID-19 pneumonia. And the latest version was issued by the Ministry of Health in April this year. That's the latest version, that's version 7. That's the version we use a lot in the treatment clinically. 那个他们那有吧？
打不开可能。
打不开，打不开那就好。 We have two kinds of protocol for treatment of COVID-19 pneumonia, one the diagnosis and treatment of COVID-19, and also we have another treatment strategy for severe and critical ill patient with COVID-19 pneumonia. Yeah, as for the criteria for severe COVID-19 pneumonia, and this is in cope with the international guideline, and the severe type is the first stress until the report rate is over 30 breaths per minute, and also the patient have a resting SpO2 less than 93%. Also, the patient PF ratio less than 3,000. And this gives, if patient meet one of any criteria, this patient is classified as severe type. And also, if the patient have respiratory failure with mechanical ventilation, either invasive or non-invasive, and classified as critical type. Also, patient have a shock or other organ failure requiring oxygen monitoring, and those are regarded as the critical type. So when we referring patient with severe COVID-19 pneumonia, it means the patient may have severe type and also critical type. That means the patient may progress from severe to critical type. And also, what are the risk factors for the exacerbation or the progression of the COVID-19 pneumonia? And also, we know that the peripheral blood lymphocytes decreased a lot in patients with COVID-19, and also progressive decline in peripheral lymphocyte is a sign of rapid progression, and also the rapid increase in blood cytokine as IL-6 or CRP also indicative the patient may progress rapidly. And also, if the patient suffer from rapid deterioration of oxygenation, that means the patient uses a very high oxygen concentration to maintain the previous oxygenation, or the patient have increase in blood lactate, that means the patient may suffer a huge insult. And also the rapid progression of pneumonia on HRCT is another sign that patient may have an indication. Also, we know that in patients with severe type, it may be difficult for them to have the CT scan done, but also we can have the chest X-ray done to evaluate if the patient has any kind of progression. And also, other risk factor for those patients to progress rapidly in their lifestyle, that means the patient have a rapid insult on their oxygenation, which leads to repeated decrease in their PO2 that may lead to the patient rapid progress, such as patient may go to the toilet without any kind of oxygen therapy, or have the dinner. Suppose the patient have invasive mechanical ventilation, the patient have kind of a dinner, and patient get the mask off his nose, the patient may have some kind of decline in PO2 that may lead to the rapid deterioration. Also, patient making calls or any kind of anxiety that may influence the patient's oxygenation. So if those kind of things happen, that leads to repeated decreased or lowering of the SpO2 below, suppose 800, 80%, then it can lead to rapid downhill deterioration of oxygenation, which might be refractory to oxygen therapy with the later multi-organ failure. So for those patients, we have to tell them to stay on the oxygen therapy even patient is dying. That's very important, because we met some kind of patient who get rapid deterioration after dining. As for the treatment for the severe cases, the guideline or the expert consensus give us first antiviral therapy. At that time in February, March, or April, we use some kind of antiviral drugs which were proven to be not effective, the ribavirin or Abidol, such kind of antiviral drugs. And also for the anti-IL-6 monoclonal antibody therapy, we also use some kind of this monoclonal antibody to treat severe cases which have a very low oxygen concentration on PaO2. We find that this kind of anti-IL-6 monoclonal antibody therapy is effective in the lysis of fever. That means during the day, the patient have the administration of anti-IL-6 antibody. In the afternoon, the patient temperature will down to normal. So for some patients, this kind of a monoclonal antibody is very effective to decrease the body temperature. And also this rise of temperature will continue. Also, steroid therapy is controversial. And actually, we did use steroid therapy for some selected patient, which we'll talk about later. And also, convalescent plasma therapy is used later on for some kind of patient because in Wuhan, in April or late March, there's some supply of convalescent plasma therapy. Also, oxygen therapy and ventilator therapy is the most important one for the treatment of severe cases kind of disease. And also ECMO is used in some patients. We have 2 cases with a patient of ECMO and one was successfully weaned and is going home now. And later, Professor Wang will talk about it. And also nutritional support and other such as antibiotics are very useful in some kind of patient because we all know that the nutritional support is important because those patients are not well nutritionalized, and also have some kind of comorbidity with bacteria or fungal infection in small numbers. So from this review by Professor Sander in JAMA, we know that at present, no therapy or no effective pharmacological therapy have shown to be effective in the treatment of coronavirus 19. And also for the steroid therapy, as we mentioned before, that in selected patients with rapid deterioration of oxygenation, that means the rapid decline in PaO2, and also rapid progression on the chest X-ray that is increased amount of infiltration on the chest X-ray, and also high inflammatory response as shown by increase in blood cytokine as IL-6 or other cytokine. In these circumstances, we might use some kind of a steroid to treat this. A very short course of steroid or methylprednisolone, about 40 to 80 per day, will be injected to the patient for about 3 to 4 days. to reduce this kind of inflammation. Also, we know that the long-term use or large dose of steroid is not recommended for viral pneumonia, also for steroid therapy. And there's some kind of report that the long-term use or large dose of steroid therapy is associated with the secondary infection of the lung. And also, doctor from Zhongshan Hospital, Shanghai, China, they have a retrospective analysis of patients in Wuhan, and they found that the patient with the application of steroid have a higher survival than those without. And also, the author stressed that this kind of result need further investigation and do not to be evaluated further. So for some kind of patient, the steroid application might be useful. And also for the convalescent plasma, as was seen in JAMA, 5 patients with critical illness with COVID-19 were shown to be some kind of effective. And in our hospital, I mean in Weijun Hospital, we use some kind of plasma, convalescent plasma, but it's difficult to interpret, so we do not have that kind of result. And for the therapy, that means oxygen therapy is essential for those with hypoxemia. So oxygen therapy with high flow, high flow nasal concentration oxygen therapy is very effective for those patients with nasal cannula oxygen therapy, which we are not meet the standard for the patient PO2 over 90%. So if the patient with the PO2 over PFO2 is between 200 and 300, we might use the high flow nasal content oxygen to treat the patient. And the initial setting was set between 30 to 50 liters per minute, and also the oxygen concentration maintained below 60%. We all know that if the patient receive oxygen concentration over 6%, there's some kind of oxygen-induced lung injury. So that's why we try to maintain the oxygen concentration below 60%. But during the application of the high flow nasal oxygen concentration, we must observe the patient closely for their oxygenation and also for their respiratory rate. And if those patients get worsening of oxygenation with FiO2 over 60 or 70, that means the patient may fail with this kind of therapy. So we must stop this therapy and give non-invasive mechanical ventilation. So patients with very high respiratory rate and also have with the high concentration of oxygen therapy, those will require non-invasive ventilation. As one doctor reported that for patients with high flow nasal cannula oxygenation, over half patients died at the 39 days. So we should monitor those patients very closely. And if the patient fail with high flow oxygen concentration, then we will start a non-invasive ventilation.
Allô, bonjour Philippe. J'ai l'impression que l'autre speaker est offline.
Oui, j'ai l'impression qu'il est déconnecté là.
Il est déconnecté. Ok.
Enfin, on va mettre en pause le temps qu'il revienne.
On va mettre en pause.
Ah, je crois qu'il se reconnecte.
Okay. Maybe I can explain to our audience a little bit the background of the Weijun Wang Hospital, if they need a little bit time to reconnect again. So the Weijun Wang Hospital is an emergency specialty field hospital built in response to the 2019 and 2020 coronavirus pandemic in China. So our four Chinese experts coming from the Renji Hospital in Shanghai. So they were working in this hospital for 1 or 2 months. So they can really share with us their unique experience. So let us start again if they are coming back. Yes, please. 蒋老师，您可以重新开始了。Please, Professor Jiang.
你需要打了伙伴，你需要知道我们。
好了，
可以了吗？ Okay, let's go on. For patient who filled with high flu, needs oxygen therapy, the patient should study with non-invasive mechanical ventilation, especially those patients with PL or FiO2 between 150 and 200. And for those patients with non-invasive ventilation, we should closely monitor the patient respiratory rate, water capacity, tidal volume, and SpO2. And also for those patients who show some kind of anxiety and some sedation will be used in order to patient have a very synchronization with the non-invasive ventilation. We all know that the prerequisite for the
Yes, I think there is the problem of the video. We cannot hear from them again. Professor Jiang, can you hear me? Okay, I think there is another problem. So I continue to explain a little bit our Professor Jiang. So he is Professor of Medicine and Chair of the Department of Respiratory and Critical Care Medicine from Renji Hospital School of Medicine, Shanghai Jiaotong University in China. And he is also the chair of ICU unit of the second department of infectious disease from Weijun Wang Hospital in Wuhan. Let me check if they are again. So great thanks to our audience. Thanks for your patience. So
yeah, they have to connect again. I think.
Yes. So our speakers will connect again. They meet some difficulties for the connection. So thank you for your patience. So maybe I can continue to introduce the background of our Professor Jiang. So he is also vice chair of the Shanghai Respiratory Association of Chinese Medical Association. He is chair of Interstitial Lung Disease Division of Shanghai Respiratory Society in China, and also member of Association of Interstitial Lung Disease of Chinese Respiratory Society and Association. He is fellow of College of Chest Physician and a member of ILD Group ERS. So in this COVID fight, common fight worldwide, he spared 2 months experience involving the treatment of critically ill patients infected with COVID-19 in Nationshang Hospital in Wuhan, China. So as you might know, this hospital was built in 10 days in Wuhan, and this hospital received all the critical ill patients and especially designed to treat the COVID-19 patients. So, 蒋老师您回来了，您可以重新开始了。So, Professor Jiang is back. So let us retake our presentation. So please, Professor Jiang.
Okay, thanks. Let's go on. As we mentioned before, that if the patient shows the increased respiratory rate with tidal volume larger than 12 mL per kilogram, that means the patient may have a very high driving pressure, which is injurious to patient lung, and also the patient have a deterioration of the PO2 or FiO2. That means this patient may not benefit from non-invasive ventilation, so we should switch to invasive mechanical ventilation. As we should know that for patients who receive non-invasive ventilation, we should use those kind of ventilator which could have the could monitor the oxygen concentration. For those kind of ventilator used for COPD patients, is not effective for those COVID-19 patients. So when we use non-invasive ventilation, we should select some kind of ventilator that could give high concentration or concentration of oxygen or pure oxygen. So that's the prerequisite for those with non-invasive ventilation, which is different from that kind of a ventilator to treat COPD patients. So this should be stressed here. So early intubation with mechanical ventilation in those patients who shows high respiratory rate and larger tidal volume with impaired oxygenation is very important. 下一张。And as in Blue Journal, that Dr. Du showed that for patients with non-invasive oxygenation, you can see that over 70% of patients died. So this kind of non-invasive ventilation is not so effective for the treatment of COVID-19. So we should monitor closely for those patients receiving non-invasive ventilation. If the patient shows deterioration within 2 or 4 hours, the intubation should be done with mechanical ventilation. So as for the invasive mechanical ventilation, invasive mechanical ventilation, so early intubation is very important.
Next.
上一个，
上
上一个，
前面
再往上，再往上，再往上，再往上，再往上，对。So early intubation is very important for patients with COVID-19. If the patient failed with non-invasive ventilation, so for patients with non-invasive ventilation, we should have intubation and also mechanical ventilation with lung protective strategy. And for some patients, we should try the lung recruitment maneuver, and also prone ventilation is very important for those kind of patients. Although we have different strategy for patients with ARDS, and it seems as our experience in Wuhan that the prone than the other, and also the lung protective strategy is the basic. And also for the lung protective strategy, 下一张, we all know that the low tidal volume 下一张啊 low tidal volume with low plateau pressure and low driving pressure and optimal PEEP is important for this kind of patients. So the tidal volume with 4 to 8 mL per ideal kilogram is used, and we should keep the plateau pressure below 30 and also the driving pressure below 15 centimeter of water. And also for PEEP, we should try to see if those PEEP is effective for those patients with COVID-19. So generally, we use PEEP over 10 to 15 for those patients with lung protect strategy. And also sedation and neuromuscular blockade is used in order the patient.
Philip, you can hear me? You can hear me, Philip? I have impression that Professor Jiang is away because of the network. But the PowerPoint continue. Philip? Gilbert, vous pouvez m'entendre?
Oui, je suis là.
Oh, oui, peut-être on peut reprendre un peu la parole. J'ai l'impression qu'ils ont eu un problème de signal. Ils sont partis. Vous voulez que je continue à introduire?
Oui, ce serait une bonne idée parce que vous connaissez mieux là-bas que moi. Hein.
Oh, okay. Okay. Tout à l'heure, yes. So I will take some time to introduce our speakers again. So Professor Jiang, he spent 2 months experience involving the treatment of critically ill patients infected with COVID-19 in the well-known Weijun Hospital in Wuhan. So his unique experience with mechanical ventilation, prone ventilation, and HFNO in the application of these measures for the patient care infected with COVID-19 is very valueless for us. So today he will spend time to share his experience with us. So Professor Jiang, I see that you are back. So please.蒋老师，您那边我看到已经连线了，可以听到我吗？您可以重新开始了。Professor Jiang, can you hear me? Yes, they are there, but we cannot hear. We cannot hear from Professor Jiang. 蒋老师，
现在怎么样？听到了吗？
现在可以了，
啊，好。
Okay, please.
Okay, as we talked previously, and the prone ventilation is important for patients with COVID-19 therapy, and the previous study have shown that the prone ventilation is very useful and decrease the death rate for patients with ARDS, and so the prone ventilation is suggested by many experts to treat this kind of patient. As our experience goes, that the patient may benefit from prone ventilation, especially early application in those patients with mechanical ventilation. And in the process of prone ventilation, the patient should sedated in order to avoid some kind of complication with the prone ventilation. And also some patients with non-invasive we tried some promethylation. If the patient capacity is maybe okay. So for patients with invasive microablation, early intubation is suggested, and also early application of promethylation is also suggested, which can benefit the patient. And the last slide is shown by Professor Richard, with presenting the characteristics in New York. As it was showing here that over 80% of patients with mechanical ablation died. That means most patients do not recover from the mechanical ablation. Also, this gives some kind of suggestion that the mechanical ablation should be used early in the treatment of COVID-19 pneumonia. That's all. Thank you for your attention.
Thank you, Professor Jiang, for your presentation. So now, to the second part. So we will retake the second part of Professor Wang Weijun. Okay. Can you see the PowerPoint for Chinese side?
Not yet.
Not yet. Okay. We can start when you see the signal. So before we start the presentation by Professor Wang Weijun, so please allow me a little bit to introduce our speaker. So Professor Wang Weijun is the Deputy Chief Physician and the head of the Cardiopulmonary Bypass Team. He comes from the Department of Cardiovascular Surgery from Lenji Hospital School of Medicine, Shanghai Jiaotong University in China. He is also the director of ECMO team, ICU, Second Department of Infectious Disease of Leishenshan Hospital in Wuhan. He spent 1 month experience in the ICU of Leishenshan Hospital in Wuhan. So now let us welcome Professor Wang to give us his presentation today. 王老师，您那边可以开始了吗？
可以。
Okay, please. Thank you.
Thank you. Hello, Chairman and our friends. I'll introduce my two cases. One of cases on ECMO on COVID-19, and our ECMO team went to Wuhan on March 7th. That time, just in fact, the increase in confirmed cases tend to flatten out. 那个手不要给我好了，小心一点。And this time we went to Wuhan, and in fact, this time has the incidence in cumulative confirmed and new diagnosis cases tend to flat. It was actually in the middle and the late stage of the epidemic. The incidents and the critical patients were mainly concentrated in Wuhan. Okay. And because it was later period to the epidemic,
So I think that Professor Wang meets some difficulties. So let me let me continue to introduce Professor Wang again before he is connected. 王教授，您那边的那个声音听不到了。王教授，您那边的声音听不到了。我这边再继续介绍一下您的背景。So Professor Wang is Vice Chairman of the Shanghai Cardiopulmonary Bypass Professional Committee and member of the Extracorporeal Life Support Branch of the Chinese Society of Cardiothoracic and Vascular Anesthesiology. He is member of the Extracorporeal Circulation Professional Group of the Chinese Medical Association of Anesthesiology. He is leader of the Life Support Research Group of the Shanghai Extracorporeal Circulation Professional Committee. So today we are very lucky to have both experts in the ICU field to share us their experience of fight against COVID-19 in Shanghai and in Wuhan. So these are two big cities in China, and they treated a lot of patients in critical illness condition. And also, please allow me to introduce you again the agenda of today's conference. For today, the agenda is we will start with two presentations given by Professor Jiang and Professor Wang. So Professor Wang will give us the case report. And after that, we will enter into our session 2, panel discussion. So for the panel discussion part, we are lucky to invite our Professor Claude Brown from Hospital Robert Schumann, who will join our panel discussion. And then we will inform all of you the next webinar, the topic and the date. So thank you again for your patience, and we will retake the presentation soon. Philippe, can you hear me? You hear me very well? Philippe, tu m'entends?
Je t'entends très bien.
Ok, je pense que malheureusement on a un problème de connexion de côté Shanghai.
Ouais.
Ils sont en train de réessayer à nouveau. Oui, dans quelques secondes, ils vont revenir
Oui, c'est leur connexion se coupe régulièrement, alors qu'elle est bonne. Quand elle fonctionne très bien.
Oui.
Mais elle se coupe.
Et maintenant, de mon côté, tout marche bien aussi.
Parfait, oui, parfaitement, oui.
Oui. Yes. So because in the beginning, I introduced Professor Jiang, but the quality of my audio is not good. Maybe I will enjoy also the time to introduce our third speaker or animators, our Professor Ge. So Professor Ge will join us in the second session of the meeting. So he is Associate Consultant Doctor from Department of Cardiology of Lenji Hospital, School of Medicine, Shanghai Jiao Tong University of China. He is also the leader of Group 4 of ICU unit of 2nd Department of Infectious Disease in Leishenshan Hospital. So as I mentioned before, Leishenshan Hospital is a very specialized hospital built in 10 days for this COVID-19 fight in Wuhan. And so they really spent very special time in Wuhan to help our colleagues there. And now the situation is stabilized. And Professor Gohen is also member of coronary heart disease panel of Shanghai Cardiology Society in China. He is member of structural heart disease panel of the Shanghai Cardiology Society in China and member of Society of Cardiac Magnetic Resonance Imaging China branch. So in this COVID-19 fight, he spent 2 months experience in the ICU of Leishan Hospital in Wuhan. So the last speaker of today is Professor Xu Xinghui. So Professor Xu Xinghui, he is Professor of Medicine, Vice Chair of the Department of Emergency, also from Lenji Hospital School of Medicine of Shanghai Jiaotong University. He is also leader of the Group 2 of ICU unit of the 2nd Department of Infectious Disease of Leishan Hospital in Wuhan. He is member of Clinical Research Panel of Emergency Branch of Chinese Medical Association. He is member of Special Committee on Chest Pain of Chinese Physician Association. So in this COVID-19 involvement, he spent 2 months experience in the ICU of Leishan Hospital in Wuhan, in China. So let us check. They are still trying to connect. So Philippe, you can still hear me? So Philippe, from your side, can you hear me? Because our Chinese colleague told me that they cannot hear me. Philippe? Gilbert, vous m'entendez? Gilbert, vous m'entendez?
Oui, j'avais coupé le micro. Hein.
Oh, ok. Parce que j'ai abonné Philippe.
On t'entend bien, excuse-moi, j'avais un problème de son. C'est bon, ça marche, pardon.
Oh, ok. En fait, mes collègues chinois m'ont expliqué que leur réseau dans l'hôpital aujourd'hui n'est malheureusement pas très stable.
D'accord.
Il s'est excusé pour ça et là, ils ont essayé de se reconnecter, mais ils ont eu difficulté pour loguer. Normalement, on a 25 places, il n'y a pas de problème.
Oui.
Oui.
On peut leur envoyer le lien éventuellement. Tu as l'adresse mail?
Le lien, j'ai déjà envoyé.
Envoyé, ok.
Oui, le lien est déjà envoyé, c'est le même lien que tout à l'heure. Oui.
Oui, non, ça ne doit pas poser de problème normalement. Ah, ça y est, ils reviennent là, je vois.
Ah, ok. Ok. Oui, je pense que le réseau a eu un choc peut-être parce que tout à l'heure, le travaux, c'est aussi de leur côté. Oui.
Ok.
C'était ça le bruit de pompe qu'on avait avant.
Oui, oui.
Ouais, effectivement, s'ils sont en travaux, c'est un souci parce que là, je vois qu'ils sont à nouveau plus là. On va attendre qu'ils reviennent.
Oui, merci pour la patience de nos étudiants, nos collaborateurs et nos orateurs aussi. On a déjà fini pour les participants qui sont arrivés juste le moment-là. En fait, on a déjà fini la présentation de professeur Jiang. qui a participé 2 mois d'expérience dans l'hôpital Weijun. C'est le fameux hôpital qui a été construit en 10 jours. D'ailleurs, vous pouvez voir sur l'écran qu'il y a une image. Et il nous a partagé son expérience dans l'unité soins intensifs. Et puis, tout à l'heure, son collègue Wang Weijun, qui vient de commencer, nous introduire un case report pour l'application de ECMO sur les patients de COVID-19 qui est gravement malade. Je me permets de reprendre quelques slides de professeur Wang. Je ne suis pas auteur, mais je me permets de reprendre. En fait, professeur Wang, il a essayé de nous expliquer la situation à Wuhan pour le COVID-19. OK. So, OK. Please, Professor Wang, you can start again. Sorry for all this problem.
Okay, let's continue. Now, this is a Weijun hospital. It is a designated hospital for infectious. And then we perform successful ECMO in its ICU. The case we performed was a male 56 years, and his incipient symptoms were fever, cough, and wheezing. And he was confirmed with CT and virus detection in outer hospital, and he underwent non-invasive ventilation to intubation and mechanical ventilation for hypoxia. And then on 20th February, he was transferred to our ICU with endotracheal intubation. And about 10 days later, his nucleic acid was negative, and his IgM antibody IgM was positive. But until he arrived at our ICU about 15 days, he had been repeated fever, unable to evacuate the ventilator, and VAP was diagnosed. Oh, the CT function. Okay, the CT. Okay, cannot.
Please
the disease is sick.
to put the CT video here for you. Okay, so now you can use it. Yes, so now the CT video is yes. So I will put the CT video again. So Professor Wang, maybe you can explain to us what we should look at on the video, please. I will start it again.
The video.
Yeah, I will replay again. So maybe you can explain to us what we should look at on this video of 15 seconds. Yes, please. I start now, please. So we can see a scan of the lung of patients. So there are some evolution of different group, different layer. So maybe you can give us some comments on this video if you want. So our audience have already have already see this video 2 times. Maybe I switch to the presentation again. You can give some comments.
The CT showed the ground glasses shadows of both, and he was hyponia. Okay, and then we performed the tracheotomy on 11th March, and he was spontaneous breathing assisted by mechanical ventilation. And we can see he was still insufficient oxygenation and CO2 retention. In fact, this was also the indication for ECMO. And then we performed the bronchoscopy and found a small amount of extremely sticky phlegm. And in previous report, pathological findings, alveolar injury with mucus exudation of cellular fibers. Thick sputum can lead to bronchial stenosis or even dead space. And it is not possible to irrigate the alveoli multiple times a day through bronchoscopy. And later we performed the patient on ECMO. Used the system was Levonorva, and the needles for oxygenator and tubing, Marquette and Edward for cannula, and the mode was VV. Adjust flow and sweep to reach the target SpO2 more than 93, and anticoagulation use the heparin to reach the ACT target 150 to 200, and APTT 84 to more than 150. So we can see the significant mismatch between ACT and the APTT. We speculate we expect to relate to consumption for long-term infectious and undernutrition, deficiency of coagulation factors, or test method. And we had no ordinary ACT machines, just found portable iStat blood gas and ACT machine. We had no more experience in using the machine. And other routine treatment contain transfusion, albumin, proper blood volume, and enteral nutrition. Of all, the basic and the crucial is that effective anti-infections. And on this patient, we take special emphasis on the airway care, and use the airway flush, and the flushing solution contains NS flush and mucus solvent, and once every hour to pour, and 2 milliliter each time. More than 2 milliliter, too much or more, can cause the patient to cough violently. And the nurse perform closed sputum aspiration every 2 hours. Turn over the patient every 2 hours and turn over 90 degrees or more, and optimized inhalation via ventilator twice daily. And outcome on fourth day ECMO, spectrum was easy to be sucked out and can be removed from the ventilator gradually. And on sixth day, flow reduced to less than 2 liter per minutes. And the patient breathed peacefully, and his arterial blood gas was normal. And on 7 days, sweep off completely, no significant change. And 12 hours later, ECMO withdrawn. And after withdrawing ECMO, 13 days, removed the tracheal cannula. And 17 days after, he was discharged. And this is his CXR after ECMO. We can see the CT. Both of them were clear. Thanks.
Thank you. So I will invite our Director of Medical Education, Professor Gilbert Massa, to kick off the second session for panel discussion. Gilbert?
Yeah, thank you very
Please
much.
allow me to show this slide.
And thank you again to both speakers. I think we don't need to say long words about the discussants because we have time to introduce them owing to these technical incidents. So we welcome Professor Heng Ji, who is a cardiologist, Professor Xinhui Xu, who is Vice President of the Emergency Room, and Professor Brown, who is Medical Director at Hôpital Robert Schumann in Luxembourg. Maybe a first question from Luxembourg, just to alternate a little bit.
Okay, so thank you so much, all the speakers from far away, for sharing their experience with our small experience. Of course, Luxembourg is a small country, and we had quite a small number of patients. And we were really so thankful to have the experience from other countries, notably from China, where a lot of patients unfortunately suffered from this disease. And the experience from China was shared. And very early in the beginning of the crisis in Luxembourg, we also established our own guidelines. Very much inspired by the Chinese colleague from their return of experience. So one question I would like to ask, so in the last weeks it was more discovered and discussed that of course it's COVID often attacks the lung, but the cells of the vascular walls, so the endothelial cells or the vessels per se, also target of this disease. So it's often considered also as a disease with a lot of vascular complications, vascular manifestations like lung emboli, like arterial and venous thrombosis. Is this also an experience you can share with us? And what were your considerations in terms of anticoagulation with prophylactic and therapeutic approaches?
看您血管的原因，看您呢就是血管的原因，那个血栓的问题，
还是没听清楚。
他讲的是血栓的问题。
我们这个病人现在还没有发现血栓。
对他提问题了。
对，他提问题就是。
Can you type the question?
Okay. Yes. I will let you know the questions. Please be patient. if you can hear me. So the question is about it's like this. I will put the questions here, what I understand.
Definitely.
Okay, I will put like this. Sorry, publish. Yes, so the question that Professor Claude Brown, he is interested in the vascular complications of the COVID-19 patients. If there are other complications like calculation system highly activated, and we have arterial thrombosis. So please share us some echo from your side. Yes. So please， 中方的老师，这个您可以回答问题了。中方的老师可以回答问题了。Okay, please. Yes, very good. Yes, please. Yes, please.
Okay. Yes. 2 weeks ago, we have our colleague working in Wuhan for 2 months in 31 bed ICU. So we discussed, we found about 90% COVID-19 patient with anemia has increased coagulation activities. Okay, it marked by increased the concentration, and we also found if the dilemma is about greater than about 1 pg milliliter, it associated with the fatal outcome of the COVID-19. So as we know, the venous thromboembolism is a potential the risk of the COVID-19, some unexplained deaths of COVID-19. So it has been reported frequently. And you know, in the ICU, some people in the critical situation need some ventilation. So a large dose of sedation and less of motivation. So in China, we have the guideline for the prevention and the treatment of venous thromboembolism associated with COVID-19. It has, as a paper, have published maybe a week ago in thrombosis and hemostasis. We can check it. So we follow the guideline in our clinical work. And in the guideline, you can find the different situation of the COVID-19 and the different strategies to provide to prevention and treatment of VTE. So the guideline is the key requirement of this guideline is all the severe and critical illness patient with COVID-19 has a high risk of the venous thromboembolism. So it is strong recommended to prevent for the VTE in those patients. If the patient absence of the country infection. So the some pharmacological prophylaxis we try is the low the weight low molecular weight heparin. This is the first line we choose. or heparin if the patient has a severe the renal impairment. We use heparin. So dose is 5,000 units twice daily as usual. If the patient with contrary infection, such as the GI bleeding, so the mechanical prophylaxis was performed. We use intimating and pneumonical compression devices. So this is what we do in our clinical work. Thank you.
Okay, thank you. 谢谢你的回答。So Cloud, I hope that their reply convenient for you and they answer your question. I hope, yes.
Yeah, thanks a lot for this information. Yeah.
Okay, please, if you have other questions, we can continue this part.
Yeah, I had a second question, which relates to other organ systems involved by COVID infection. So clearly the lung, of course, is the central organ which is attacked by the virus. But there had also been reports that there might be a cardiac involvement in terms of myocarditis or other kind of cardiac damage. And also the neurological system might be involved. So what has also been described in Italy, for instance, we described also quite a lot of different forms of neurological disease. Is that also an experience which had been made in China?
Yes. 就是他的问题是想问一下，您是否观察到在那个 COVID-19 的患者当中的一些器官特异性的损伤模式，比如说心脏病、心肌炎、肾病或者神经系统的疾病。我这边把问题再打出来。So I will also put this question in the publish mode. Like this, our audience can also see this question. So this is the question in brief, summary. So please, our colleague in Shanghai, if you have some comments on this, please.
Yeah, can you hear me? I'm Dr. Ge from Renji Hospital. Dr. Bernard, Dr. Masada, good morning. I'm a cardiologist, so I want to talk about something about the cardiac involvement in the COVID-19 patients. I think the outbreak of the COVID-19 disease was in last December. So in the early February, there was a report that a 53 years old woman with confirmed COVID-19. She had a symptom of myocarditis. So later there were several reports that around 30 to 40% of patients they had elevated myocardial injury indication like TNI or BNP. So it raised a big question whether besides the lung, whether this virus can directly target other organ like heart. A lot of people do a lot of researches. But the later autopsy studies, they don't find any virus located in the myocardium, but in the interstitial tissue of the heart, they found some monocytes and they found edema or something. This time in the Weijun Hospital in the ICU, we performed the echocardiographic examination in about 33 patients. To see whether there are some functional or structural changes of the heart. So our result is in patients without no history of cardiac disease, like
Yes, I think our friends from Shanghai meet some difficulties again. So let us be patient. Let us be patient, and hopefully they will be back soon. So I
I think we can take the opportunity to ask Professor Brown about the experience in Luxembourg with extrapulmonary features of this disease.
Yeah, again, of course, the experience is quite limited. As the colleague from Shanghai also stated, we saw that that some of the people in intensive care suffered on a cardiac level, but so far very difficult for us to differentiate. Is it, let's say, an indirect consequences of the severe lung involvement? We had what we saw. We definitely had patients with cardiac rhythm problems, perhaps also induced by the severe disease. What we also saw, because in our treatments or our treatment guide, we and of course that can be debated, and this is also controversial. We included hydroxychloroquine as a treatment in patients with severe manifestations, and as the most may known, of course, hydroxychloroquine has an impact on the QT time. That might also be responsible for some cardiac arrhythmias. That's what we discovered quite regularly in our patients, be it due to the disease or to other things. So cardiac problems might be indeed one of the things we most see in most or a lot of patients. Otherwise, of course, and that's also a question I wanted to discuss with the colleagues from China, what will be the long-term sequelae in these patients? So clearly they are very ill, they're suffering, they have a long stay in the intensive care unit, and had a huge impact on neuromuscular function and others, of course. So these people might take a long time to get back into a normal life. So and what we also see, these people are very long in our units, be it on the normal units, also in the intensive care units. So the huge time of treatment in the hospital is also very probably a huge impact on the psychological side of these patients.
Yes, I also believe that the psychological impact on our patients are really visible and important, because I heard from some friends in Wuhan, they got sick and in the ICU for COVID-19, and they spent 1 month in the block. When they are clinically cured, they are allowed to go back to their family, get back to home, but nobody wants to talk with him. So he feels very lonely, and this is really a difficult situation for our patients. So I think from the society, the whole society, we need to give more healthcare, humanity care as well for the long-term healthcare system. Yeah. So
yeah. I do agree. That's certainly something which we also will see and learn with all these patients. There's one aspect also in terms of psychological view. We also had the experience that patients who went into this trouble of respiration, so who had been hospitalized on the normal ward, and had really a limit situation in terms of oxygenation. What often these patients had been very anxious, so they really suffering that way. And when they got some sedative treatment, it enormously helped also on the respiratory level. So often it was able to prevent them from going to intensive care unit, eventually being intubated, when we got satisfying oxygenation just also by having the sedative component of the treatment. And so that also helped very much, because these people were anxious, and of course being and in a belly-prone position for hours is also not that comfortable. It's also a very difficult experience for these patients. So.
Yes, and as we know that our human body is also an integrated machine. So the brain, the heart, lung, and the endocrine system is a whole machine is together. So if they suffer from one organ, they might have other impact on other organs. So we need to consider everything at the same time, because also these critically ill patients, they suffered already the basic problems like hypertension, diabetes, or other cardiovascular disease. So when we treat them in the first stage for the COVID-19, we have no choice to immediately do some operations or other treatment. So we somehow delayed our treatment for their basic disease. We have to control the infectious condition. So this will also extend our treatment time window for the whole battle to help them. I think it's a very complicated situation. Yeah. So Gilbert, you please give your expert comments.
Well, actually, I'm not a COVID expert by my background training, but I wish to get back to the question about this diffuse coagulopathy. Claude mentioned it before, and I wanted just to ask Claude's opinion, how far some of these cardiac problems that you see in these intensive care unit patients might be simply linked to this multiple coagulopathy and some kind of right heart failure or suffering, because the indirect idea leading to this hypothesis is that there are now several papers that demonstrated an adverse prognostic value of a high D-dimer titer.
Yeah, definitely. So this test, this test of activation of the coagulation pathways is also part of our analysis, which are made at the entrance of the patient in the hospital, because it definitely has prognostic value. So you can clearly see patients with initially very, very elevated D-dimers have a negative prognosis, and it's often these patients who will also end in the intensive care unit. One lesson, or one very fascinating, I can say fascinating case was that of a woman who came in the hospital and with severe desaturation, so the oxygen content in the blood was very low, and it was somewhat disparate to the CT scan. So it was not clearly explained by the CT scan. And then we decided to make an injected scan again, so to see whether there might be an obstruction of the lung vessels. And clearly, this woman had lung embolism, so clots in the pulmonary veins, arteries, but in a very atypical pattern. So it was not the pattern of a thrombosis, which then eventually embolized in the lungs, but it was more atypical, and it was really confined to the regions of the lung, which were also considered as infected with this ground glass pattern and so on. And also when doing then ultrasound and very deep ultrasound of all the veins in the body, we didn't find any peripheral thrombosis. So the hypothesis was then that there might be like local thrombosis, which developed in the arteries of the lungs. And this had in some way be confirmed also by autopsies, which were basically performed in Italy. We also found a huge amount. It was about 70 or 80% of all people who had been who had got this autopsy. When these doctors in Italy also found thrombosis or embolism in the lung vessels. And again, a very atypical pattern, more developing locally and then spreading more to the direction of the heart. So a very new pattern, which we did not had in any diseases before. And clearly that shows that this disease is highly thrombogenic. And also in France, there have been reports from doctors who saw very atypical thrombosis, both arterial and venous thrombosis. So this virus clearly is thrombogenic. And in a recent, very interesting, very short article in the Lancet, they showed electron microscopy images from organs with some virus particles inside endothelial vessels in different regions of the body, lungs, kidneys, and so on. So again, new experience we're doing, and clearly everybody's learning a lot from this COVID pandemics.
Gilbert, I just heard from our Chinese side, so they really have difficulties for today to be back again, but they are still in front of their computers. They want to express their acknowledgement to our organization. And for questions of Professor Claude Brown, they will try to answer by email. And we can also integrate in our final video for our students, if you agree. And yes, so if you agree both, so we can also finish our webinar today, and hopefully next time we will do better.
I think this is a very reasonable proposal, because we were waiting for some feedback from our Chinese colleagues that we definitely cannot retrieve today. But this is, let us say, a reason to continue our webinars with hopefully better technical conditions next week. So I think it is my turn to thank, of course, our Chinese colleagues for their huge contribution, which is very valuable for us, for our patients. To thank the discussants, and in particular Claude Brown, who was able to find some spare time in the busy working day. Thank you also to Xian Qing, who is really the link, the ambassador of Luxembourg University and the Chinese institutions. I'm very happy that she accepted to work with us since first
it's
of
my
April.
pleasure.
Though in so far virtual conditions. Thank you once again to Philippe, who is our technician for these events, and thank you to Nathalie, who is in the backstage but very effective with helping out to diffuse the information about the events. And so thank you to all colleagues who joined us this morning. I wish you a nice working day and a fruitful afternoon. And maybe, Xian Qing, it's now the time to announce the next event.
Yes, so the next event normally is also next Thursday. So next Thursday, let me check. The date is the 7th May. So we will have appointment here online, either in the morning or in the afternoon. I will check again with our speakers in China. So they come from the same hospital, so Nanjing Hospital of Shanghai Jiao Tong University. So they will continue the session that we cannot unfortunately finish today. They will also focus on the intensive care aspect to share with us their experience. And also after that, we will have a very interesting topic on the existing strategy of the confinement. So the Chinese colleagues, they are facing the same challenge with us. So they are back to work, back to the normality life several weeks ago. So they really want to share their feelings and discuss how to better prepare and avoid the second wave of the COVID-19 with us. So this has been programmed for the 14th May, and this talk will be given by our Fudan University colleagues. So there is Professor Wang, who will give us this discussion part. And it's our pleasure also to inform you that in the 21st May, we are lucky to have invited Professor Yu Zhui from University of Wuhan. So he is the head of the Department of Emergency of Renmin Hospital. So he will share with us some unique experience in the Department of Emergency during the fight against the COVID-19. So he also spent several months in the Jinyingtan Hospital. So the Jinyingtan Hospital is in parallel compared to the Leishan Hospital. It's a hospital specialized for emergency treatment for patients of COVID-19. So he has his special experience and will share with us. And just after that, the 28th May, we are honored to have Professor Hou Wei from the Institute of Virology in Wuhan, from the laboratory of P4, to tell us some story behind the COVID-19. So he recently published in the New England Journal and the Journal of the Lancet some new discovery on the COVID-19, and he will also introduce some research aspect of this virus and the development of the treatment on the antivirus aspect. So let us look forward to all this exciting webinar, and thank you again. Yes, and happy 1st of May, Labor's Day. Maybe it's this reason that the network doesn't want to work in China, because it's already their afternoon.
Okay, preparing the party.
Yeah.
Okay, well then I think we can say goodbye. See you next week, and we will also insert some local generated broadcasts on COVID issues that we will announce by emails and on the website in the coming days. So the most important perhaps is to say goodbye and stay healthy.
Bye. See you next time.
Bye. See you.
Ok.
On est déconnecté?
On n'est pas encore déconnecté. Je vais juste dire à Asvin. Oui. J'ai dit à Asvin d'arrêter le live.